Well, thank you so much. It's so nice to be here in Savannah. This is my first time to Savannah, ever. So my wife will be joining me about midnight tonight at the airport, so we hope to have a little time to see the city tomorrow. What I wanted to go over today, and there's no quiz at the end. No. Oh, so no quiz at the end. Is that better? Okay. No quiz at the end. Rest assured. What are some of the decisions you have to make? How can palliative care help? When you should make them? And what's the best way to make apple butter? Or peach cobbler? My mother, I grew up on a dairy farm in rural Ohio, and my mother was an excellent cook. My father was a pretty decent cook. And I've continued the love of cooking, and I'm trying to teach my 3 nephews. So my sister has adopted 3 boys at birth. There's a couple of them there. And I realized I turned 62, and I'm actually happy to be senior, and because now I get half-price movie tickets. Yay! But having lived through some serious illnesses and recognizing that I'm mortal, I really want to take good care to teach these kids how to cook and to enjoy cooking and baking and exercise as much as I do while I still can. And that's going to be the message, is do all these things while you still can. And frankly, baking has played a very important role in my medical career. How many of you remember what X-rays are? How many of you have ever lugged around a stack of X-rays? I can remember when you took a stack of X-rays to Dr. Mary Ann Turner, the very best radiologist, and said, you know, this patient's coming in to see me at 2 o'clock tomorrow afternoon. Any chance you could put all these up on all the whole boards that went around of X-rays and tell me if the cancer is getting better or worse? And she would roll her eyes. I learned that if I baked sour cream or applesauce gingerbread and took a plate of warm gingerbread and left it on top of the X-rays, I would be guaranteed a call from Dr. Mary Ann Turner, the GI X-ray expert, within 45 minutes. And in fact, we teach that as part of our Palliative Care Leadership Center. I actually have on most of my thumb drives what we call academic detailing recipes. Easy things to make to get your doctor's attention. Ginger snaps, peach cobbler, and I'm always looking for recipes. One of the things I'd love to do is do a hospice and palliative medicine cookbook. I was going to use the title Recipes to Die For, but somebody's already used it. It's about Southern Wake recipes. So I figured really comfort foods, or the last cookbook you'll ever need, or good to the very last drop, something like that. All right. Uh-oh. Can you hit the next slide? The laser pointer still works. Maybe just hit the down button. And is the little USB thing still fully plugged in? There it goes. Okay. So this is all about choices. And you have choices to make. It's hard for your healthcare professionals to guess your choices. These clothespins are there because our daughter came home after her first week of first grade, and we got this phone call from the teacher. Things are really terrible at school. We think your daughter should go back to kindergarten. And we asked our daughter, and she said, "Oh, it's not so bad, you know." And we went in and talked to the teacher with our daughter there, and our daughter suddenly bursts out into tears and says, "There aren't any clothespins." And we're looking at the teacher, we're looking at our daughter, thinking, where did this come from? And it turns out in kindergarten, You have tasks for the day, and they're on clothespins. And you get to choose your clothespins. You can be line leader, you can be recess leader, you can be first. There weren't any clothespins in first grade. So that's the only thing that was upsetting her. And she's gone on to do pretty well. She has 2 master's degrees, and she's a third-year medical student. But it's really hard for your loved ones to guess your choices unless you discuss them. In fact, your best significant other has a 50-50 chance of guessing rightly about things like CPR and resuscitation. 50-50, unless you discuss it. My wife would want me resuscitated about 130 times. Yeah, keep shocking him, keep pounding on him. Punitive. So what are some of the decisions you have to make? The easy ones actually are the advanced medical directors. So how many of you have advanced medical directors? Okay, I guess I can go. Yeah, it's wonderful. You take a representative audience in the United States, and it'd be more like 10%. And we've not had much of these conversations in the past couple of years. It's your choices about your care when you're seriously ill, living well. I would start by asking patients, do you have a will? Because that's medically safe. And then I'll ask, well, do you have a living will? What's that? Or they'll say, oh yeah, we filled one of those out. Do you have a durable power of medical attorney? Who will speak for you if you cannot? We saw 3 patients today on rounds, and the team really had only partly gotten around to asking some of those really difficult questions. We'll concentrate on those first. Maryland makes it easy. In fact, most states make it easy. You can go to the website for the state health ad directive, and it's a free download. No need for attorneys or fees. You can do it for free. You just have to have 2 people sign off as witnesses. We'll have it cloud-based, hopefully, in the next year. So once you have it, you can actually upload it to a state registry. And all you have to do is send email messages to 2 people to sign that they're witnesses to your electronic signature. Georgia makes it easy, too. Georgia, of course, is very much more serious. So we have a plain black and white. So that's what it looks like. Not quite as inviting. But it's pretty much the same. And it says, if I'm in any condition that I initialed in Section 6 above, and I can no longer communicate my treatment preferences after reasonable and appropriate efforts have been made to communicate with me about my treatment preferences, that is a mouthful. So you work your way through this, and you may need an interpreter. You may need a couple stiff drinks or a couple stiff coffees. Try to extend my life for as long as possible using all medications, machines, or other medical procedures that in reasonable medical judgment could keep me alive. If I'm unable to take nutrition or fluids by mouth, then I want to receive nutrition or fluids by mouth or other medical means. I have patients who want this. I'm a breast cancer doctor. And I have some patients who will say, do everything possible. Every breath of life is precious. When you've lost your life, you've lost everything. And it's giving up to not do that. And I'm fine with that. And I think 99% of doctors would be fine with that choice as long as it's your choice. I do have to tell you that the most distressed families we see are when their loved one has died in the ICU from a disease that was clearly going to take their life. So the most distressed families I see are when somebody has pancreas cancer, somebody has lung cancer, somebody has refractory heart disease, and they end up dying in the ICU when all the medical team is just sort of shaking their head and saying, wouldn't it have been better for him to be at home, surrounded by his family? Those are the most distressed families we see completely, and it can all be avoided if you put this in place. So at the bottom there, if I'm unable to take nutrition by mouth, I want to receive nutrition by tube or medical means. That's fine too. I'm okay with that. I do point out Maryland is a fairly Catholic state, and I sit next to a sister on a couple of, from the Little Sisters of the Poor on a couple of committees, and she says, well, Pope John Paul II declined a feeding tube when it was offered. So there's a lot of Catholic tradition for not having to do everything either. It's really None of this is justified so much in religion, it's just our own culture. So how many of you have heard of a MOLST or a POLST? Physician's Order for Life-Sustaining Treatment. Really important because this takes that advanced directive and then, see, isn't this upbeat? Isn't this cheery? Sorry. It takes it into a form that looks like this, and it says, if my body dies, I want CPR done. And I'm fine with that. I had one of my patients die, and her last words to the EMT team, she was dying of metastatic breast cancer at home, her last words to the EMTs who were coming out from fire rescue were, intubate me. And intubate me, put me on a breathing machine. And when she got, I actually met the family down in the emergency room, and here she is, she's clearly dying of her breast cancer. And her husband explained, well, we have a developmentally challenged son at home, and she really didn't want to die at home and have him see that. So it made perfect sense. And we called, the husband was there, we got both the parents on the a line, and everybody agreed that this is fine to actually take her off the ventilator, give her medicines to keep her comfortable, and allow her to die with some peace and comfort in the emergency room. And that's fine. That's a great way for her to handle it. Most people would prefer to be at home. And most of us in the medical profession would choose this one, no CPR, prior to arrest, provide passive oxygen for comfort, keep me comfortable, but don't intubate me or keep me alive artificially. There is a great web-based tool to do this. It's critically important to do the estate planning. But there's a lot more stuff that you want to do about choosing a medical decision maker, decide what matters most in life, choose how much flexibility. If you want to, you can tell others about your illness and ask doctors the right questions, so this will link to your doctors. And this is a free website. It's actually the best of them all, called Prepare for Your Care. Just Google Prepare for Your Care, and you can go in and create a real document that's very helpful, and it will walk you through the process. And it's not all the gobbledygook that I showed you on the last slides. It's very much direct and in English. All right, so here's how you make applesauce. First, you go to Rittman Orchards, and you have each boy pick out 4 of the different types of apples. It's an old Amish Mennonite orchard near where my sister lives, where I grew up. And you pick out each 4 apples, so you bring home a huge bag of apples like this, and then you cut them into quarters around the core. You try not to get any boys' fingers in it. We had a couple cuts the last time. We had no cuts this past weekend. And then you boil it till soft. And then you put it through a Foley food mill. What greater fun for a 12-year-old, 10-year-old, and 8-year-old than to take steaming hot apples, dump them in, and then grind them up and get applesauce coming out the bottom. If you have, anyone tried this with kids or grandkids? Is it fun? It's absolutely the most fun you can have with kids. You add sugar, add cinnamon and cloves. More is always better. And then you put it back in the pot and you boil it until it starts to go plop, 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 until it looks like, hey, that's a volcano. And then you know it's almost ready. You want to test it to make sure that it gels by putting it on a cold plate and tipping it upside down, and then you hand it to one of the boys to eat. Other things you need to frankly discuss with your loved ones are cardiopulmonary resuscitation, CPR. So I have 3 friends from the Project on Death in America who sentenced themselves to watch 3 years of every episode of Chicago Hope and ER. So like preparing for a Super Bowl weekend, they did a marathon Chicago Hope ER, and they watched every single episode. What's the success rate of CPR on TV? 2 out of 3. 2 out of 3. So no wonder we have sort of unrealistic expectations. In U.S. hospitals, it's only about 14%, but it's very predictable who's going to survive CPR. If you're dying from an irreversible cause, dying from pancreas cancer, dying from really advanced heart failure, woman we saw this morning dying of infections that can't be treated, it's close to zero. I mean, it really is zero. And all your medical team will know that. We're sometimes reluctant to say that because it sounds so grim. But the last thing we want is to let people have unrealistic expectations. But if you watch TV, it would make perfect sense to do this, because at least you can survive till the next episode, right? Hopefully your season doesn't get canceled. But it can break ribs, it can be... And the thing about CPR is it only returns you to the state where you were before. It doesn't actually fix anything. And some families finally say, oh yeah, he's still going to have kidney failure, he's still going to have liver failure, he's still going to have that serious infection. Maybe that's not going to be any better. So if you feel strongly about being kept alive on machines, just tell somebody. Write it down. Most healthcare professionals really don't care what your choice is. We just want you to have a choice. Angelo Volandes just published a book called The Conversations, and he has videos that show people undergoing CPR. He does CPR on a mannequin, and it really helps people understand and make the point that CPR doesn't actually fix the underlying problem. It just brings you back to where you were before. And if it wasn't fixable then, it's not going to be fixable. And once you see the video, about 80% of people who wanted CPR beforehand switches down to about 20%. There's still about 20% of people in every walk of life who still want CPR, and we're fine with that. So this is from one of the airlines on the way down. Anybody who's been in an airline has seen Caras. You don't get the deal you want, you get the deal you negotiate. In business as in life, you don't get what you deserve, you get what you negotiate. So the way your last months or years or decades of life go isn't necessarily what you want, it's what you negotiate. How many of you have a cardboard box of Polaroids from the 50s, 60s, and 70s at your house that are unlabeled? So that's your task for this lovely sunny afternoon, is to go home, find that box of Polaroids, and figure out who they are and label them. Because my father, who died when I was relatively young, didn't do that. And my mother died, and she said she was going to get around to doing it, and now she doesn't. So I've got all these wonderful photographs of people who look really interesting, but I have no friggin' idea who they are. So that's your task for the afternoon. Palliative and hospice care. When you think of hospice or palliative care, what do you think of? You usually think of game over, in loving memory, or this frog grabbing the heron's neck, never, ever, ever, ever give up. That's what most of us think of. Or as one of my friends who's a geriatrician says, the deep and abiding desire not to be dead. So hospice was developed in the 11th century. And it really came to a forefront during the Crusades. And hospices were places where you went to die, often on a journey where you didn't have anybody to take care of you. And it's providing care and not curing. Dame Cicely Saunders, bless her soul, was the one who really pioneered it in England and then imported to this country. It also provides assistance for patients' families to help them cope. And that's one of the biggest things that hospice does, is help your family cope with your illness once you're gone. So a whole bunch of us in a number of fields about 30 years ago said, well, why do you have to wait till the last 6 weeks of life to get something that seems to make sense for most everybody? Why can't you do this with curative care? Why can't you do it when somebody has a big heart attack? Why can't you do it when somebody's having a lung transplant? Why can't you do it when somebody's having curative therapy for their Hodgkin's disease? And you know what? You can. We just sort of moved hospice upstream. It's specialized medical care, so it is a board-certified specialty focused on providing patients with relief from pain, symptoms, stress, whatever the diagnosis. Its goal is to improve quality of life, and it's a team. When I'm in oncology clinic on Wednesday mornings, it's just me. Just me telling bad news. When I'm in palliative care clinic, I've got me, I've got an advanced practice nurse, I've got a chaplain, and I've got a social worker to help cover all bases and provided at any age. So it's medically appropriate goal setting, open and honest communication, and the best symptom assessment and control. No matter what the diagnosis. We see everybody who gets a heart transplant for planning, so we can help them figure out what's going to happen, good or bad. And the day after their transplant, we're the people at their bed saying, I don't care that your stitches hurt. You're going to get your butt out of bed, and today you're going to be sitting in the chair for 2 hours, and tomorrow you're going to be walking down the hallway. Got it? So that's what we do. But won't your doctor tell you if things are bad? The answer is no. Not unless you specifically ask. And even sometimes when you ask, your doctors won't tell you. About 75% of doctors will tell a person with incurable cancer that they can't be cured. But we typically do it once at the beginning of disease, and then, quote, it never comes up again, end quote. If you put an anthropology student in a medical oncologist's office and have them listen to all the conversations, it's about the chemo, it's about the disease. There's almost nothing about, well, what's really going to happen to me? Can I survive this? Patients are thinking this, but they're not asking it. It turned out that in the one study of 35 lung cancer patients, they learned more about what was going to happen to them from other patients in the waiting room than they did from direct conversations with their doctors and nurses. It's just a fascinating thing. It's just so hard to talk about this stuff. And if you're an oncologist in particular, you have to do it day in, day out. It's just easier to pull back a little bit. Only about 25% of us will have a discussion about actual prognosis or impending death, and it's usually really late. It's usually about a month before we die. We're trying to change that in the medical scene, but it's going to take a while. Isn't this stuff cheery? There's no easy way I can tell you this, so I'm sending you to someone who can. I sat next to a liver doctor, and this person, we do a lot of liver transplants at Hopkins, and this liver doctor, the woman in front of us, we're having a family meeting, the woman in front of us was still drinking. His liver had failed. She was bright orange. She was clearly going to die in a couple of days or a week or two. And this liver doctor was saying, well, if we get her infection under control, and if there would have to be 13 medical stars aligned exactly in a row for this woman to ever be considered for a liver transplant. And the poor family didn't know what this guy was saying. He's the person you'd want to take care of you if you needed a liver transplant, trust me. But if you want the straight truth, what this family was saying, is she going to ever get better enough for a liver transplant? And I could look them in the eye and say, no. It's been on the table for about 6 months. She's gotten much worse during all that 6 months, and there's just no way that she's going to ever get a liver transplant. It would kill her to go through it. But let's take advantage of the time that you have with her now. You got a box of Polaroids at home. It's gotten a lot of bad press. Isn't hospice and palliative care part of the death panels? There's a flap about a year ago about the UK hospitals paid to put patients on a death pathway. It was actually a symptom management pathway, but it didn't kill people. Diseases still killed people. And then Sarah Palin came out with Obama's death panels. Actually, one of the strongest proponents of having these discussions is very conservative former Senator Bill Frist from Tennessee, cardiac surgeon and founder of HCA Columbia, one of the private for-profit health firms. And he says, frankly, it's our patriotic duty to communicate our wishes. He's on record as saying everyone should have these conversations. And in fact, he's putting his money and a bunch of other people's money where their mouth is, and he started a home care company that's going to do home-based palliative care and help people make these choices. So it's not just from leftists, it's from rightists as well. All right, so how do you put the applesauce that you've made into a container? You go to Lehman's Hardware, purveyors to the Amish, and the largest seller of non-electric goods in the country, just down the street in Kidron. It's a great place to visit if you're in Ohio, in Amish, Ohio. I used to go to auctions there on Thursday, and everything would be in German. And the Amish farmers would bring out great big wads of, $100 bills and, buy $3,200 worth of cattle on Thursday auction day. You have to get there pretty early for that. Their business really boomed during Y2K, the year 2000, when the world was going to come to an end and there wouldn't be any electricity. And they got a whole bunch of people who ordered irons, the old-fashioned irons that you put on the stove. And so they'd get these irons that didn't have any cords on them, and they'd call up and say, "How does this work?" So the business skyrocketed. They couldn't get enough Mennonite girls to come in and answer the phone. So you go to Lehman's and you get these nice plastic containers. The nice thing is you don't have to boil these. And you simmer till thick. You taste regularly. We had some nice, good, fresh snow in Kidron this past weekend, so I asked the boys to get out fresh snow, and then we dribble hot applesauce onto it. And then if there's any left, after 3 hungry 12, 10, and 8-year-old boys get done eating it, you put it into jars like this. And that will feed 3 hungry boys for about a week. Wait till they get 16, 14, and 12. So, back to palliative care. This is what got us involved in it. We showed if you round on hospital patients and you see them on day 1, this is their pain score, 0 to 3 scale. If you have palliative care, you can make pretty much every symptom go down in 24 to 48 hours. If you've got a team whose job it is, like your hospice nurse comes out and says, "How are you? What's your pain? What's your pain level? Is that a satisfactory level of control for you?" When that's your job, you get pretty good at it. So that's what got us interested in doing this. And then there started to be some randomized controlled trials. And this was done in upstate New Hampshire and Vermont by Marie Bacchitis, who randomized patients into usual medical care or usual medical care plus meeting with the palliative care team by phone 4 times a week. And I won't bore you with any slides. Remember, there's no test. This is quality of life, and it's better. And this is symptoms, and they're better. And this is depression, which is better. So even though you're having more discussions about things being pretty bad, you're less depressed and less anxious. And this is a survival curve. This is 100% of people being alive at the beginning, and at 12 months, here, there's almost 60% of people who have the symptom control are alive, compared to about 40%. It's about a 20 out of 100 person difference in survival. Not quite statistically significant, but pretty darn close. And that's what every study to date has shown, is that palliative care and hospice does not kill people. It's the disease. In fact, if you get your symptoms managed, you're going to live longer. This is a randomized trial that was in the newspapers in 2010 with lung cancer patients at Mass General in Boston. And this group got regular medical oncology care from Jennifer Temmel's colleagues at Mass General. And this group got their regular lung cancer treatment, but they had a palliative care team that they met with once a month. They had a better understanding of their prognosis. They had a better understanding that the goals of care were to keep you alive for as long as decent and then transition to a good death. They used less IV chemotherapy, less aggressive end-of-life care, much less chance of CPR, and triple the time in hospice. But look what? They lived almost 3 months longer. Wow. If this was a new drug, we'd be wanting it, right? And not only did they live longer, but this is their quality of life. Their quality of life is twice as high. They had half the rate of depression. This is the rate of depression here. Half the rate of depression, a little less anxiety, and their mood was markedly better, just because they had symptoms managed. And this is hospice. If you use hospice for any amount of time, you'll live longer than those who don't live hospice. Don't use hospice. How many of you have heard hospice kills people? I still hear it. It actually doesn't. It's the opposite. So this is why doctors like me don't have these conversations. They don't really want to know. And people do want this information. It'll make people depressed. And it actually doesn't. It'll take away their hope. It actually doesn't. We measured what happened when you had an honest discussion using the Hope Index. You're thinking, how do you measure hope? There's actually a 12-question instrument you can use to measure hope pretty well. And when we told people their actual prognosis, their hope didn't change at all. No matter how hard you try, you cannot stamp out somebody's hope. It's not within our medical power. We can give realistic forecasts. Physicians will say, well, no one really knows for sure, only God knows. We can always estimate hours to days, days to weeks, weeks to months, months to years, or a long time. And it's always culturally appropriate to ask, how much do you want to know what's going on? Are you the sort of person who wants to know all the details? Why? Most of you, I heard a few chuckles, so you know Johnny Carson and the great Carmack, who would guess things. There's really good evidence that palliative care relieves depression, relieves caregiver stress, improves symptoms, allow more people to die at home, but it's hard for your healthcare professionals to guess what you want. And it's really hard for your family. That's a real surprise to me, that your family, your loved one, will have about a 50-50 chance of guessing right or wrong. It's amazing. Been studied in multiple settings. Part of it is your loved ones don't want to let you go. Or in my case, my wife would want me to be kept alive so she could do more CPR, break more ribs. Yeah, keep. And this is where we are in the country right now. So these are seriously ill cancer patients across the country 2 years ago. And 30% die in the hospital. How many people want to die in the hospital? How many people want to die at home? How many people would prefer not to die at all? Okay, I'm in that crowd. But very few people want to die in the hospital. But overall, it's about a third of us. These are Medicare-age patients with serious cancers. Only half ever use hospice, which is amazing to me. It should be close to 90% use hospice. 65% of people are hospitalized in their last month of life. If you had 30 days left to live, how many of you would want to spend 10 of those days in the ICU? Any hands? Okay. Sometimes that's inevitable because people get really sick. And sometimes life is very unpredictable and diseases are unpredictable. But most of the time it's not. It's because we haven't had these discussions and we end up in the emergency room at 3 o'clock on Tuesday morning and the team there doesn't know who the heck you are. Your living will is someplace back at Aunt Wanda's. Sound familiar? Yeah. 25% are in the ICU. It's a wonderful place to be if you need to be there, but not a place to be if you've got advanced cancer or heart disease. How many of you have a will? Great. Okay. So I always start with asking, do you have a will? Because it's easy and simple. But then we'll go, are there any family issues that you need to settle? We have this on a checklist that hopefully will show up on our computers and make it easier for the young doctors to remember this, or me to remember it now that I'm over the age of 50. You know that phenomena where you put your car keys in your hand, turn your hands over and say, now where are my car keys? Are there any family issues that you need to resolve? Are there any spiritual issues? How many of you have had a healthcare professional ask you about your spiritual nature? 1, 2, 246 people in the room, 3, 4, 5. 5 divided by 246. That's a pretty small number. How many of you would like your healthcare professional to know about your spiritual side? Most. It's about 70% nationwide, even higher. And it's pretty easy for doctors or nurses to say, is religion or spirituality important to you? Easy and simple. And then this life review. There's a wonderful book called Dignity Therapy by Harvey Chochinov, who's a good friend and a psychiatrist in Manitoba. And he says when you get to the point of having a serious illness, you should be spending as much time doing things that you want to do. And if you have important messages to pass on, by gosh sake, write them down, DVD them, cell phone them, put them on paper. He was working with first-generation Canadians, eh? All of whom had immigrant stories, eh? And it turns out if you transcribe people's life stories and put pictures next to them, people's dignity at the end of life goes way, way up. Sort of like the storybook program the storytelling program you hear at the Hospice of Savannah. It's really important for people to tell their stories. One of the patients we saw this morning, she just wanted somebody to hear her story, which was an amazing story. How do you want to be remembered? What are you most proud of in your life? What have you accomplished in your life? When did you feel the most alive? I ask people, what are you hoping for? And then do the hardest thing for a doctor to do, which is SUAL, shut up and listen. I have a friend who was a physician, an oncologist, who did a year's chaplaincy training. The hardest thing for her to do was to listen. And the data on palliative care are so clear that our professional society wrote in 2012, and we're going to re-up it in 2015, that with 6 clinical trials showing benefit and no trials showing harm, anybody with any serious cancer illness should have access to palliative care. And it may be that their oncologists are really good at it and doing it already. Some of us are, some of us aren't. But if you know somebody who's sick, and somebody who still has unrelieved pain, shortness of breath, nausea, vomiting, depression, spiritual distress, existential distress, that's a really good call out for a palliative care consult. And don't ever feel bad about asking for it. So what are the decisions to make? How can palliative care help? It can help with most things. When to make them? Not 2 a.m. Thanksgiving night in the ER or the ICU. How many of you remember the Seinfeld episode about pulling the plug? A few people. Mrs. Kramer, when he's watched a movie about a woman going into a coma, and he didn't realize that people could get better from a coma. So when Elaine reaches down to pull the plug out from her DVD player, he thinks she's pulling the plug on him, and don't pull the plug! It's not 2 a.m. in the morning with a young intern who's sleep deprived, and she has no experience doing this. It is when you're well. As soon as you or a loved one are diagnosed with a serious illness, you don't even have to wait for a serious illness. All of us have a mortal condition which is known as life. And one of the sayings is, life is a sexually transmitted disease with 100% fatal outcome. And for gosh sake, don't make your kids do this. So do have these discussions when you're well. Do document your choices. In most states, it's free and easy. Doing so will help you live better, possibly or probably actually live longer, and help ensure that your choices will be honored. And having cooked breakfast pancakes for my 3 nephews, you notice that they're African American. My wife's adopted these 3 African American kids at birth. That, of course, makes me their Uncle Tom. Which luckily none of them have gotten to read in high school yet, but I'm sure we're going to have some discussions about that. But anyway, you can decide whether you want blueberries in your pancake or on the side of your pancake or not at all. So thank you very much.